So we're going to move on now and talk about natural disasters and weapons of terror. And we'll also talk a little bit about explosions. So there is a chart in your book that I would like you to look at that specifically addresses natural disasters. It's just a chart, you look at it, it's just giving you examples of what that may look like. So things like hurricanes and flooding and tsunamis, right? Those, like, I just remember right away. There are certain things that we consider to be weapons of terror, and they, can come in different ways. So they can be biologic, chemical, and radiologic. So as a nurse, you just need to be aware that patients may present with injuries because of any of these things. And we also are going to talk about explosions that can happen, and they can also be used in they can actually, explosions can happen naturally, or they could be purposefully by somebody, setting off an explosion because they want to, bomb up a building. So we want to just talk a little bit about blast injuries as well, so we know how they may look. All right. So a blast may result from terrorism, but can also occur anywhere at any time if the right or wrong circumstances come together. So the particular example that you've been given here is welding inside of a tank that formerly contained tar, but was now properly cleaned, can result in an explosion as well as severe tar burns to the worker. Another way that they described welding, when I was looking it up because I wasn't familiar with this term, they said that it's metal pieces or parts that can get heated, and then so I guess they can also explode. All right. Here we have just a couple of explosive devices that people can use. So a pipe bomb is something that terrorists like to use. Apparently this contains low velocity explosives. It may also contain nails or other implements that cause more damage when the explosive ignites. And then another one that they like is a Molotov cocktail. Apparently this uses a common flammable liquid such as gasoline in a glass bottle and a source of ignition such as a rag. So these are just examples of explosive devices. So if somebody has suffered a blast injury, they are going to have very particular manifestations. So we just describe some of these for you. So the physical injuries will vary depending on the type of blast and how close the patient was to the blast itself. So one thing that we talk about is a blast lung, and apparently this results from the blast wave as it passes through the air-filled lungs, and you end up with hemorrhage and tearing of the lung. Then you're going to have ventilation perfusion mismatch and possible air emboli. This is going to show up as dyspnea, hypoxia, tachypnea, or apnea, depending on the severity, cough, chest pain, and hemodynamic instability. So here you just want to provide respiratory support as quickly as possible. And the patient may also need things like endotracheal intubation and mechanical ventilation. Another thing that you want to monitor for in a patient who's had a blast injury is a tympanic membrane rupture. So we'll talk about the tympanic membrane when we're talking about the ears, but this is basically your eardrum. So this is a very thin layer of tissue, and ideally what it does is it receives sound vibration from the outside and then transmits it to the inner ear, and then you're able to hear something and understand what's going on. So this one is because of it's a pressure wave, and TM is the body's most sensitive organ to pressure. So this is why this is going on here. So the severity would depend on how close the patient was to the source. So some of the things that the patient may report are things like hearing loss, tinnitus, pain, dizziness, and otorrhea. And apparently a lot of these do heal spontaneously, where some of them do not. So you just want to have just a loose understanding of some of these. Just know that, blast injuries, there's certain things that can happen and what that may look like. All right. From a blast injury, you can also get abdominal and head injuries. So you can get things like abdominal hemorrhaging and internal organ injury. For the internal abdominal injury, you're going to see things like pain, guarding, rebound tenderness, rectal bleeding, nausea, and vomiting. And this should make sense to you depending on the organ. I mean, that's all this is describing is, okay, if that's shattered in some way, well, what am I going to see, right? Head injuries can also happen. So here you may see things like concussion as common post-blast, and the way you're going to treat that is going to be the same as how you would for somebody who suffered a head injury. So we're going to monitor our special populations very closely when it comes to blast-associated risks, and older people, right? So they're susceptible to bone fractures because they have decreased bone density, and so this can be exacerbated by the explosion. Pregnant patients apparently are susceptible to placental shear forces that may result in a rupture of placenta. People with mobility disabilities may have difficulty extricating themselves from the site of the blast. So maybe the building blows up and they see people running, and people who can't walk can't get away as quickly as they would like to. Animals may need special help. People that have vision and hearing problems, all of that you need to take into account. So the National Organization on Disability is one institution that tries to kind of predict what disabled people may need ahead of time and provide training if needed. And as nurses, regardless of how the patient presents in the emergency department, you have to be able to do an assessment and be able to kind of, try to figure out whether or not what you're witnessing is a blast injury. So pretty much that's true for anything. A patient shows up, you should be able to hopefully diagnose them in some way, and then try to kind of come up with why you think they're there. That's like an obligation apparently that we have. All right, so now we're talking about your biologic weapons. So these are things that spread disease among the general population or the military. So for sure in the military, when people are at war, this is definitely what's going on. So we're going to talk about some of these biologic weapons, and we'll talk about some of the chemical weapons, and just to see if there are any differences. So the biologic weapons can be used for sabotage, such as food or water contamination with a small target area, or may be used by global terrorists with intentions to enable global objectives. So apparently because of modern travel, spread of infection may occur in areas thousands of miles apart, and that is definitely a true statement. So we need to be aware of potential signs of biologic weapon dissemination, and a lot of these signs and symptoms are similar to those of common disease processes. So the biggest thing for us is we need to figure out what the isolation practices are depending on the infecting agent. Like we need to figure out, okay, do we have to isolate this patient, right? We're always using standard precautions. Some agents will require transmission-based precautions. So transmission-based precautions, you need to know how that agent is transmitted. You know what it is, how is it transmitted, do we need masks, do we need gowns, right? So that would all fall under you knowing the transmission-based precautions. Whether we're using terminal disinfection and disposal of wastes depends on the infecting agent. So what do we need to do in terms of getting rid of this thing? So here we've got some common biologic weapons. So one of them is anthrax, and apparently this is a gram-positive rod that lives in the soil in the spore state throughout the world. Apparently it becomes liberated when exposed to air and is infective only in the spore form. So contact with infected animal products, in particular raw meat, or inhalation of the spores results in infection. Cattle and other herbivores are vaccinated against anthrax to prevent transmission through contaminated meat. So that's a scary thought. So essentially all the meat we're eating is vaccinated against anthrax. So another reason to stop eating meat, as hard as this is. I mean, there's just so many things we seem to be able to get from these things. From meat, I don't know. Anyway, so it is an aerosol, it's odorless and invisible, it can travel a great distance before disseminating. So the site of release and the site of infection can be miles apart. Your clinical manifestations for anthrax. So what you're going to end up with is hemorrhaging, edema, and necrosis, and there's apparently an incubation period of 1 to 6 days. There are three main methods of infection, so skin contact, GI, ingestion, and inhalation. Under your skin, which apparently is the most common infection, you're going to get things like edema with pruritus, a macule and papule formation, and you get ulceration with 1 to 3 ml vesicles. You may also get a painless eschar, which falls off in 1 to 2 weeks. Ingestion of the anthrax, you're going to get fever, nausea, vomiting, abdominal pain, bloody diarrhea, and occasionally ascites. If you're having things like severe diarrhea, you get a decreased intravascular volume, obviously, and the bacterium apparently targets the terminal ileum and the cecum, and you can end up with things like sepsis. Inhaling anthrax, so that would probably be something you just want to know, is that the worst type is the inhaling anthrax. You get the more severe clinical manifestations. So its symptoms mimic those of the flu, and usually treatment is sought only when the second stage of severe respiratory distress occurs. So initial signs and symptoms include cough, headache, fever, vomiting, chills, weakness, mild chest discomfort, dyspnea, and syncope without rhinorrhea or nasal congestion. So in terms of anthrax, I guess just know that there are different ways you can get it, and that the inhalation one is the worst one. So the recommended treatment, and this is probably what I would focus on also, is knowing where some of these medications belong. Even though they didn't make it on your list, you just kind of want to be able to know, okay, if I see something like penicillin, right, I know that that was a recommended treatment for anthrax. Like, know where the different types of meds are falling under. So here you have penicillin, you have erythromycin, gentamicin, doxycycline, and you want to try to start treatment within 24 hours to prevent death. If there's a MCI situation, mass casualty situation, treatment with ciprofloxacin or doxycycline is recommended, because you can usually find these oral antibiotics. They're stockpiled. So this is part of the emergency and disaster management plan. Like, you would make sure that you have cipro and doxycycline in your stockpile. That way, if there's an emergency, you can use these medications if, for instance, maybe you didn't have penicillin or something like that. Right? So you're going to treat this for 60 days. Patients who have been directly exposed to anthrax but have no signs and symptoms of disease, cipro or doxycycline is used for prophylaxis for 60 days. So if you've been directly exposed to anthrax but you have no signs and symptoms of disease, you can get the cipro and the doxycycline as prophylaxis so that you don't get it. So it's helpful for the patient. So another thing you want to be aware of when I'm talking about some of these biologic weapons is what type of precautions are in place, right? So for anthrax, they're saying that standard precautions are the only ones indicated to protect the caregiver exposed to a patient infected with anthrax. The patient is not contagious, and the disease cannot spread from person to person. So you're going to clean the equipment using standard hospital disinfectant. They do, however, recommend cremation, because they're saying that the spores can survive for decades and represent a threat to morticians and forensic medical personnel. So we talk about anthrax and then we talk about smallpox, and literally for both of them, cremation is recommended. So it's recommended for anthrax, but for smallpox, it's like beyond highly recommended. Like, they say do it because there it lasts even longer. So there is a vaccine for anthrax, but apparently it's only being used in the military and only for it's only in the military and only for what am I trying to say here? I wasn't trying to say anything. Okay, so there is a vaccine for anthrax, but it's only used in the military. All right. And then we have smallpox. So what is smallpox? Smallpox is described as a deoxyribonucleic acid DNA virus It is extremely contagious. You want to pay attention to those things. So which one's contagious, which one is not. It's extremely contagious, spread by direct contact, by contact with clothing or linens, or by droplets from person to person only after the fever has decreased and the rash phase has begun. Considered eradicated in 1977 and stopped worldwide vaccination in 1980. So the people that have the high likelihood of exposure to smallpox are encouraged to receive the vaccination. So maybe people like ED nurses, for instance. So this is not something that everybody's getting anymore, the smallpox. Clinical manifestation. So what are you seeing in these patients? You're seeing things like a high fever, malaise, headache, backache, and prostration. So prostration is just being extremely, extremely debilitated and extremely, extremely weak. Apparently you get 1 to 2 days, a maculopapular rash appears, and it starts on the face, mouth, pharynx, and forearms. And then the rash progresses to the trunk and then becomes vesicular to pustular. And there's a large amount of virus in the saliva and pustules. Okay. So contagious only after the appearance of the rash. And there are 2 forms of smallpox, which I don't need you to memorize this at all either. Apparently there's a variola major is more common, and with this one you get a higher fever and more extensive rash. Then you have a hemorrhagic smallpox, a subtype of variola major. You get all of the signs and symptoms in the previous one, but you also get a dusky erythema and petechiae, leading to frank hemorrhage of the skin and mucous membranes. So that's what's going on with this one. So under smallpox, what is our treatment looking like? So supportive care with antibiotic agents, and then here you're noticing that the patient has to be isolated with the use of transmission precautions. Laundry and biologic wastes should be autoclaved. So this is like a pressure cooker to kill off any bacteria using steam and incredibly high temperatures. All right. So laundry and biologic waste should be autoclaved before being washed with hot water and bleach. Standard decontamination of the room is effective, and all people of household or face-to-face contact with the patient after the fever, so remember after the fever begins, should be vaccinated within 4 days to prevent infection and death. All right. A patient with a temperature of 101 or higher within 17 days after exposure must be placed in isolation. And so here you're noticing that cremation is preferred for all deaths because the virus can survive in scabs for up to 13 years. All right, so just pictures here of smallpox and chickenpox, which we don't really talk about chickenpox, but I thought it was an interesting picture. Then we have this thing known as a severe acute respiratory syndrome. So not all of the mass casualty biologic events are terrorist-based, right? So air travel and worldwide trade have increased the possibility that any contagious disease may spread rapidly. So for sure, we're experiencing COVID-19 right now. So SARS, this was back then, was caused by a virus officially named SARS coronavirus. And 2 to 10 days, people at risk include healthcare workers who have had unprotected exposure to SARS coronavirus. So currently we're dealing with COVID-19. And I would not be surprised if you had questions on infection control measures and standard precaution measures on your NCLEX. I was talking to one of my students the other day, Yesenia, who just passed her boards over the weekend. So we're chatting, and she was telling me about her experience on the NCLEX, and she said everything was selected that apply. Everything was either about ethics, making ethical decisions, or about priority, and it was definitely about infection control. So she wasn't sure if it was because of the COVID, but she definitely had to know about PPE, donning and gloving, how to put on your setup, how to take it off, those types of things. So that was really interesting. So I wouldn't be surprised if you guys had similar types of things. All right, and then we have chemical weapons. So this is another category. So we've looked at biologic weapons, and now we're looking at chemical weapons. So these are can cause injury or death and cause panic and social disruption. So we have different examples here. So we have vesicants, nerve agents, blood agents, and pulmonary agents. So they all vary in volatility, persistence, toxicity, period of latency, and exposure length. All right, so we kind of want to limit their exposure, and we want to decontaminate as soon as possible, basically. So we start with the vesicants, and you've been given a couple of examples here. So these guys, so these are all the examples. So they cause blistering and burning. So initially this can feel like, or it can look like a large superficial to partial thickness burn. Respiratory effects can be serious and cause death and requires intubation and bronchoscopy. So things like decontamination with soap and water are essential. And then they advise that you do not scrub or use hypochlorite solutions because that can increase penetration. So the hypochlorite solution, apparently this is an ion composed of chlorine and oxygen. So an ion, ION, composed of chlorine and oxygen. So you're not using those because they can increase the penetration. If your eyes are exposed, you're doing copious irrigation. So keyword, vesicants, blistering, and burning, like a burn, basically. Your nerve agents, so these are some examples you've been given. So apparently these can be inhaled or absorbed percutaneously or subcutaneously. So inhale, absorbed percutaneously or subcutaneously. Their deal is they inhibit cholinesterase, so they cause cholinergic symptoms, progressing to loss of consciousness, seizure, copious secretions, apnea, and death. So think myasthenia gravis, right? This is basically what's going on over here. So treatment is decontaminate with copious amounts of soap and water or saline solution for 8-10 minutes. The water is blotted, not wiped off skin to minimize chances of rubbing more of the agent into the skin. You are trying to maintain the airway as much as possible. You're suctioning. Apparently do not use plastic airway equipment because plastic will absorb the sarin gas and may result in continued exposure to the agent. So very similar to myasthenia gravis, you're seeing atropine, right? Because it's an airway thing that's happening here. So here you're giving atropine 2 to 4 milligrams administered by IV, followed by 2 milligrams every 3 to 8 minutes for up to 24 hours of treatment. They can also do IV atropine 1 to 2 milligrams per hour until clear signs of anticholinergic activity have returned. So clear signs of anticholinergic activity include things like decreased secretions, tachycardia, and decreased GI motility. Right? So then you know that your medications are working. So they can also give another medication known as Protopam. And this one is given 1 to 2 grams in 100 to 150 mLs of normal saline, administered over 15 to 30 minutes. All right. What else did I want to say about this one? So let's see, this particular medication has no effect on secretions and may have any of the following side effects. So side effects from our medication, the Protopam, includes things like hypertension, tachycardia, weakness, dizziness, blurred vision, and double vision. You can use things like Valium to control seizures and decrease fasciculations and to alleviate apprehension and agitation. So remember fasciculations, we've had this before, right? So under seizures, I think we came across this term. So that weird twitching that happens, right, in your face. So that's here. And so apparently if you're in the military, they give you this special Mark 1 automatic injectors that contain atropine and 600 milligrams lidoxine chloride as protection. All right, and then we have the blood agents. So here we have examples given: hydrogen cyanide and cyanogen chloride. And apparently they have a direct effect on cellular metabolism, and you end up with asphyxiation through alterations in hemoglobin. All right, and apparently cyanide is an agent that has profound systemic effects. So what are you going to see under your blood agents? Specifically under cyanide, it can be ingested, inhaled, or absorbed through skin and mucous membranes. So what you end up with is respiratory muscle failure, respiratory arrest, cardiac arrest, and death. So patient needs to be intubated. You have to do a rapid administration of amyl nitrate, sodium nitrate, and sodium thiosulfate, specifically for the cyanide exposure. Apparently, unfortunately, the medication you give can have some side effects, of course. So with sodium nitrate, you can have severe hypotension, and thiocyanate can cause vomiting, psychosis, and arthralgia and myalgia. You can also instead give cyanide, for cyanide poisoning, give vitamin B12A. And let's see, apparently hydroxycobalamin binds cyanide to form cyanocobalamin, vitamin B12. It must be administered IV in large doses. So takeaway is just there's an alternative treatment for cyanide, and you can give vitamin B12A. Okay. Under the vitamin B12 can result in a transient pink discoloration of mucous membrane, skin, and urine, which I think you're familiar with already. In higher doses, tachycardia and hypertension can occur, but they usually resolve within 48 hours. All right. Your pulmonary agents include phosgene and chlorine that destroy the pulmonary membrane. So you're ending up with capillary leakage, results in fluid-filled alveoli. So essentially getting things like pulmonary edema, shortness of breath. Let's see, an initial hacking cough is followed by frothy sputum production. Here all you need is a air filter mask to protect healthcare personnel. Okay, so the pulmonary agents. And then radiation. So we've talked about radiation, but now we're talking about it in the sense of either it naturally, you're exposed to radiation, you're minding your business, and maybe a radiation plant blows up, or terrorists are using radiation, like what's his name in Syria used radiation to kill off, like, part of his population. So we're just talking about now radiation in general, right? So it can happen because of nuclear weapons, nuclear reactor incidents, or exposure to radioactive samples. So we already know that radiation is affected by time, distance, and shielding, and there are different types of radiation exposure. You want to think of this in terms of from the from the worst, which is incorporation, to the least, this is bad English, to the one that's not as bad. So you have external radiation, contamination, and then incorporation. So when you're thinking of incorporation in terms of radiation exposure, know that the radioactive material is literally inside your body, cells, tissues, and all your organs, like it's doing some serious damage. All right. So for external radiation, all or part of the body is exposed to radiation. The person is not radioactive and does not require special isolation or decontamination measures. In contamination, so different types of radiation, this is how they categorize them. For contamination, the body is exposed to radioactive gases, liquids or solids, either externally or internally. If it's internal, the contaminant can be deposited within the body, requires immediate medical management to prevent incorporation. So the worst thing you want to prevent is incorporation. All right, for radiation decontamination. All right, so let's say a plant bursts somewhere. So let's say BMCC is a hospital, and then down the block where McDonald's is a radiation plant, and then that plant blows up, and we know there's radiation exposure. What we're going to try to do is prevent contamination of all of that radiation at that McDonald's down the block to our hospital at BMCC. So when we're trying to triage the patients, we're doing everything outside the hospital to prevent contamination of our hospital, which is BMCC, the facility, right? So you want to cover the floor to prevent the tracking of contaminants. You're going to use strict isolation precautions. All air ducts and vents should be sealed to prevent spread. The waste is double bagged outside of the facility and labeled radiation waste. All must be disposed in color-coded yellow and magenta canisters. So these would be unique to your hospital, but at where I worked, we had yellow. Other places may have magenta, or they may have both even. You just have to know which ones are which for the radiation. So let's see, for staff protection, so water-resistant gowns, 2 pairs of gloves, caps, goggles, masks, and booties, and dosimetry devices, which we've discussed before, right? So key thing is we're triaging outside the hospital, and then as much as possible, we're trying to prevent contamination so we don't track it everywhere when we're putting them in a hospital. All right. So patients are surveyed for radiation and directed to the decontamination area. So this thing has happened at McDonald's. We are surveying them. We're sending them to the decontamination area. We're going to safely decontaminate them with soap and water. And so you notice in the second bullet, we're trying to decontaminate each patient outside the ED with a shower, wash off that radiation as much as we can. So water, tarps. Is a sheet of strong, flexible, water-resistant or waterproof material, right? So water, tarps, towels, soap, gowns, all patient belongings, and so on must be collected and contained. Patients are resurveyed and reshowered as necessary. Showering should be performed to not contaminate clean areas with runoff from the showering. So we're showering them outside the hospital in a particular area, but we're making sure that whatever water is draining off of them is not leading into the hospital. It's going a totally different direction, and it's being contained in a different way or collected in a basin or something. Biologic samples, so nasal and throat swabs, blood are collected to determine internal contamination levels. If there are internal contamination levels, which would look like that last category, which was incorporation, then you know that you're in trouble. So you're going to do additional treatments. You're going to do things like catharsis and gastric lavage with chelating agents. So chelating agents are agents that bind with the radioactive substances and are then excreted. All right, so that's more work for us in terms of trying to save this patient. So we have what is known as acute radiation syndrome that can happen. So this can happen after exposure to radiation. So keyword is the dose of radiation, not the source, but the dose of radiation will determine if acute radiation syndrome is present. Let's see. So factors that determine whether acute radiation syndrome develops include a high dose, minimum 100 rad, and rate of radiation with total body exposure and penetrating tight radiation. So each body system is affected differently by ARS. Systems with cells that rapidly reproduce are most commonly affected. So your blood cells and your GI system. And this is obviously true. We know this about radiation because we know that in cancer patients, when somebody's being treated with radiation, we are going for the cells that are rapidly reproducing or growing, right? That are proliferating. So that is definitely a true statement. So presenting signs and symptoms determine predicted survival. So if somebody's been exposed to radiation, how they present, their symptoms would determine whether or not the patient is going to survive. So there are three main categories. So probable survivors, they have no initial symptoms or only minimal symptoms. So maybe they show up with nausea and vomiting. These symptoms may resolve within a few hours. So you want to do things like a complete, you want to do a thing like a complete blood count. And then, if the patients are okay, then they're good to go. Your possible survivors, they present me things maybe like nausea and vomiting that persist for 24 to 400 hours. 24 to 48 hours. There's a latent period there. So latent period means like it's a slow down period, or it builds up, during which things like leukopenia, thrombocytopenia, and lymphocytopenia happen. So barrier precautions and protective isolation are implemented, especially if the patient's lymphocyte count is less than 1,200. So here, supportive treatment includes administration of blood products, prevention of infection, and provision of enhanced nutrition. So it's as needed, once again. And then the improbable survivors, so these are the ones that have received radiation of 800 rad, and they have total body penetrating irradiation. So people in this group demonstrate an acute onset of vomiting, bloody diarrhea, and shock. And if they're having neurologic symptoms, then that suggests a lethal dose of radiation. So they still require decontamination to prevent further contamination of the area and of others. Personal protection is essential. Because it is virtually impossible to fully decontaminate these patients. All of their internal organs have been irradiated. So let's see. So the survival time is variable. Death usually occurs swiftly due to shock. If there are no neurologic symptoms, patients may be alert and oriented, similar to a patient with extensive burns. So in a mass casualty situation, these patients will be triaged into the black category, where they will receive comfort measures and emotional support. If it is not a mass casualty situation, aggressive fluid and electrolyte therapies are essential. So, perfect example here. If it's a mass casualty situation, you're going to categorize them as black. If it's not a mass casualty situation, the same patient is going to be seen first and they're going to be like aggressively treated. All right. So, main takeaway is that there is such a thing as acute radiation syndrome, and it depends on the amount of radiation you get. And then there's categories of survival based on the amount of radiation exposure that the patient has been exposed to. All right, so this is pretty much the end. So this is just a funny slide here of a nursing student just having a hard time. Alrighty.